each and every one of you for joining. I first wanted to give a warm welcome to each of you for joining us on this podcast. Pleasure to have you, Dr. Gupta. Pleasure to have you, Dr. Alterman. Pleasure to have you, Dr. Perera, and pleasure to have you, Dr. Corey. It's basically we're going to speak about the importance of limb loss awareness and foot health awareness, but also how it kind of links back up to peripheral artery disease, and just to kind of highlight some of the issues that we could see patients experiencing with regards to these diagnoses. It's also important because April marks National Minority Health Awareness Month. And I think that, with the stats that are out there with regards to peripheral artery disease, over 12 million Americans are diagnosed with it, right? Over 70% of Americans are not aware that they might have some form of peripheral artery disease. And if you look at some of the statistics from the Amputee Coalition Organization of America, as well as the Critical Limb Ischemia Global Society, PAD is obviously affects a lot of individuals that even rival most cancers that are out there, maybe with the exception of lung and bone cancer. And I think that, there's a lot of topics with regards to peripheral artery disease. But what I'd like to focus on specifically is some of those factors. And I'm going to leave the floor open, in terms of conversational decorum, of some of the outstanding issues that we need to advise patients on. And the one that comes to mind, and if you'd like, Dr. Alterman, if you'd like to maybe make a few comments regarding this, is dialysis patients and the link up with peripheral artery disease. If you could kind of explain a bit in terms of dialysis access care and how that ties back to those patients that are diagnosed with peripheral artery disease.
Sure. Thank you, Vin. As you know, a big emphasis of our practice is taking care of patients with both chronic kidney disease and peripheral arterial disease. To your point, there is a fair amount of crossover and linkage between risk factors for both. The lion's share of people that have severe chronic kidney disease are affected with hypertension and diabetes. And we know that at least 15% of people with end-stage renal disease will have clinically significant peripheral arterial disease. So this certainly requires careful attention and screening. In terms of risk factors that we see, particularly in the Mid-South, given the geography and access to care, these are substantial issues for our community. And patients that are seen with either PAD or chronic kidney disease, and both, I would say the lion's share of our patients have all of these underlying risk factors and some element of chronic kidney disease as well.
Okay. Yeah, I think you've touched on a very important point there, Dr. Alterman, because, you'd mentioned CKD, chronic kidney disease, and, dialysis access care. I think that, and it's safe to say, and this is something I'll go on a bit later in the podcast on when it comes to some of the, factors with regards to, having a limb salvage program or looking at limb preservation. I think that, we talk about diabetes, we talk about cholesterol, we talk about smoking cessation, we talk about some of the factors, when it comes to even neuropathy and how that impacts, those candidates that are diagnosed with peripheral artery disease. But if you may, on that topic, Dr. Alterman, there's this syndrome that they talk about, which is Steele syndrome. Is that something that, again, patients that are probably more at risk if they are diagnosed with Steele syndrome when it comes to peripheral artery disease?
Yeah, that's a good question. There definitely is crossover in risk factors. There is a subgroup of patients who need dialysis access that are thought to be at a higher risk of the so-called Steele syndrome, which is really arterial insufficiency and sometimes can provoke severe nerve symptoms in the limb. People with calcified vessels, elderly women, small blood vessels, and even inflow disease can be at risk, and also certain kinds of dialysis reconstruction. It definitely raises our concern when patients present to our clinic with what they believe is neuropathy, but sometimes is conflated with ischemic symptoms. We also see this predominantly in patients who have longstanding diabetes. And oftentimes they are under the impression that it is just my nerves or neuropathy, when in fact they have very severe peripheral arterial disease. This is why careful clinical assessment and appropriate screening is very important.
Yeah. Yeah, well said and well thought of in terms of that explanation, Dr. Alterman. In terms of, Dr. Diaz-Perera, we talk about the difference between limb salvage and limb preservation. Is it okay for you to kind of elaborate in terms of, explaining that? Because at the end of the day, saving limbs does save lives. It's something that we in your profession have come across through so often. We talk about this all the time, but it cannot be underplayed. Can you kind of explain that process with regards to limb salvage and limb preservation?
So, limb preservation is more of a broad term or a phrase we use to describe preserving someone's limbs as a general idea. But specifically, the term limb salvage is a medical term where we rescue a patient from losing his or her limb when they are faced with an amputation due to vascular disease.
Right.
So, to some extent, it's semantics. It's one is a pure medical term, other one is a general description. But for practical purposes, we can use the term limb preservation because everybody would relate to it and identify it and also understand it. So the idea of limb preservation is important because we, we lose when we lose or anyone loses a limb, they lose more than just a leg. They lose their functional independence immediately, and restoring that back is not a given. A significant percentage of our major amputees never walk again. And teaching an old man to walk again, just to borrow a phrase, is harder than teaching a toddler to walk. They have lost their core strength. They are already carrying multiple medical disorders, and they may have other ailments such as joint disease that limit their ability to mobilize. So all these things cripple them permanently and for life. And in addition to that, someone who has lost a limb is at high risk of dying too because it increases their workload in terms of work on the heart and the lungs and all that. And there are many other things that can contribute to their uh, contribute to hastening their death. So the the importance of limb preservation is that in turn you also preserve their functional lives.
Yeah, that's a lot of food for thought there, Dr. Diaz-Perera, because we look at it and we don't realize on face value that we look at it. Okay, this is someone that's gone through an amputation, which could have been prevented had been early detection, and we thereafter look at it. If you look at in terms of morbidity, after that's actually happened, 2 years later, the impact and the severity of losing that limb, and as you rightfully said, how that could lead to death. So it sounds like there's not been a lot of focus and attention, when it comes to peripheral artery disease. And if you look at the sheer magnitude and of numbers of patients that are getting diagnosed with this, that is starting to come to the fore, be it through certain organizations or committees that are now, providing some literature out there with regards to the education around PAD. But I think to that point, and it's a perfect segue now for me to kind of move forward to Dr. Gupta, something that I'd like to discuss about as the pillars of limb preservation. We talk about medical management, we talk about revascularization, we talk about wound care, we talk about neuropathy. I think that in summary, if I may, that kind of covers what's important when we talk about the pillars of limb preservation. With your expertise and knowledge there, Dr. Gupta, is that something you can kind of expand on in terms of what I've just mentioned?
Definitely. Thank you for having us, Vin. So somebody with peripheral arterial disease, basic first step is, pillars of management would be medical management. And generally, medical management would involve, cessation, for, cessation of smoking, putting patients on aspirin, generally on one of the statin drugs for plaque stabilization. I think those are the medical management is first and foremost. A lot of PAD patients are asymptomatic or mildly symptomatic. Early claudicants, for example, people who walk and they hurt, generally that is all that is needed. And as symptoms progress, at that point, if it becomes lifestyle limiting and a person has failed medical management, or somebody who has critical limb ischemia, such as tissue loss or rest pain at night, at that point, we recommend intervention to treat the peripheral arterial disease. And that could involve either endovascular therapy or open revascularization. So that is kind of, in a nutshell, what treatment would involve for peripheral arterial disease.
I think that, as subject matter experts, and obviously have been doing cases upon cases of this, we talk about the impact of, poor circulation and making sure that, you reduce that need where you have proper blood flow into the lower vessels. We mentioned the arteries all the way to the feet. In terms of the treatment, and just to provide a bit of an explanation there, how would you classify treating, a stenosis versus an occlusion?
Essentially, stenosis just refers to a blockage that is not expanded upon the true lumen or the full lumen of the blood vessel itself. So, meaning when we talk about occlusion, we're saying that the blood hits the blockage and cannot get past it. A stenosis means a narrowing or a reduction in the flow circumference in a certain area in the blood vessel. We treat stenosis a lot of times with balloons called a balloon angioplasty, where we stretch the luminal diameter of the blood vessel to enhance the circulation and improve the flow. We also do other techniques besides balloon angioplasty. Sometimes when the narrowing gets so severe, we sometimes put in a stent, which is a metallic tube that helps expand the blockage, similar to how, or reduce the blockage and expand the lumen of the blood vessel itself. Similar to how cardiologists sometimes will place stents in the heart. A lot of times will place stents in the leg arteries. Occlusion essentially means that there's a total blockage, a 100% blockage somewhere in a blood vessel that is obviously severely impacting the flow past it. And a lot of times we're able to perform minimally invasive procedures on both stenoses and occlusions using catheters and wires and the methods that I just mentioned, either with balloons or stents. Sometimes we do use devices to kind of clean the plaque from the arteries as well before we put in balloons and stents. So we have lots of different minimally invasive techniques that we use now that are durable and provide good results as sort of a first-line therapy for patients who have symptomatic peripheral arterial disease, like Dr. Gupta mentioned, either having pain at rest, or sometimes, especially our diabetic patients, can develop ulcers or non-healing wounds and require intervention to improve the circulation to promote wound healing and preserve limbs.
Yeah, that's important that you touched upon that there, Dr. Corey, because we talk about limb loss awareness and how it links up back to peripheral artery disease. And we look at below the knee revascularization that we've in essence been speaking about. But I think it's also important to understand for the viewers out there and the listeners that it's not just below the knee, right? We've also got below the ankle, right? Intervention that's needed. And you touched upon this, Dr. Corey and Dr. Diaz-Perera, where we spoke about foot health awareness. At the end of the day, we look at it and we realize, and I'm sure you've seen this firsthand, that we mentioned the diabetic foot ulcers, those wounds that are not healing. When it comes to this specifically, when it comes to, foot health, is there a particular evaluation? Is there any screenings? Is there, indications that patients rather come in earlier rather than too late so that this is something that is addressed and taken care of, before any potential immediate intervention is needed.
When is that for me?
Yes, Dr. Diaz-Pereira.
Yeah. So, yeah, it's a good question. So, screening is a very complicated topic, but uh, it is fairly easy to do in our patient population because, like you have already alluded to, most of our vascular patients also have diabetes mellitus, and some of them have other comorbidities and system diseases like kidney failure already. High blood pressure is rife in this patient population. So they are already closely engaged with either a specialist or a primary care doctor's office. So they can undergo some level of both clinical and diagnostic screening. This is especially pertinent to the diabetic patients where most of the medical societies would recommend protocol-based screening. And a lot of the endocrinologists and the other doctors who manage these diabetics already do that. So what we would encourage is to refer these patients early to our clinics for a vascular evaluation. Just because you see a surgeon don't mean that you're going to get an operation. You Most of the time in my clinic, what I give is a recommendation. Often it is a recommendation saying that you don't need surgery. So, meaning it's a full on evaluation about your vascular status, which is often very reassuring to a patient. We are sometimes able to tell patients, listen, you will never ever have to see a vascular surgeon again. Now, this is important. This may not be important to a 28-year-old, but if you're a 57-year-old with diabetes, mellitus, high blood pressure, and other medical problems, to be reassured about their vascular disease is huge. So, in that context, what we recommend is uh, primary care or other provider-driven referrals for early screening.
So I like that explanation a lot, Dr. Diaz-Pereira, because, given it some thought, I think a lot of people put off what is needed. When it's something that's elective, when it comes to, a complication or surgery, it's almost as if, without instilling a bit of fear, you've been informed or educated that you need to go and see a physician, go and see a doctor, go and see a provider, get to a clinic. But most often than not, this could be, as you hit the nail on the head, avoided if this was detected early or if the patient actually had the wherewithal to come through for a visit. I think that's, a perfect opportunity for me to talk about the importance that your practice has as Vascular and Vein Institute of the South. The leading practice across the tri-state area. We're talking across Tennessee, we're talking across Mississippi, as well as Arkansas. You've got numerous office-based lab locations as well as a surgery center. But I think, Dr. Gupta and Dr. Alterman, I'd like to, if it's okay for you to, field the next question. How important is being a tertiary institute to your practice?
I'll take this. So I think it's, we call it the fried chicken belt here, the tri-state area. Unfortunately, it's one of the most underserved area in the country. If you look at heat maps for diabetes, if you look at heat map for hypertension, kidney disease, it's one of the highest prevalence of these diseases here. So patients who are diabetic, who are hypertensive, coronary artery disease, end-stage renal disease, as we discussed earlier, they have a very high prevalence of peripheral arterial disease. So what happens is, for one, there's very high prevalence of the disease. Secondly, because of lack of primary care physicians, lack of, initial early diagnosis, which you'll see in a lot of metro areas, patients, when they actually show up to an emergency room or to a specialist like us, their disease is really advanced. Like, for example, patients we see for peripheral arterial disease, I would say 60 to 70% have critical limb ischemia at the time of diagnosis or at the time when they come see us, which is extremely rare. If you look around the country, it's 20 to 30% probably, maybe even lower. I mean, the more well-educated somebody is, or more access to healthcare they have, they get diagnosed earlier. Here, especially in Arkansas and Mississippi,
Most patients actually present when they have ulcers or gangrene or ischemic rest pain. Rare to see somebody with claudication or just, Charlie horses when they are walking. So coming how it's important to have a group like us. I mean, there are very few groups who actually go to the patients. So where we differ is we are not just in the metro area of Memphis. We actually have outlying offices. We have 15 offices in 3 states. We go where the patients are. A lot of these patients do not have, the economic resources to actually travel 2 hours, 3 hours to Memphis or to a big city for just a consultation. Having offices in these small areas allows us to see patients, do all their diagnostic testing. And, you mentioned OBLs. We actually have a fair number of OBLs and, surgery centers close to these patients themselves in Mississippi and Arkansas. And this allows us to treat them there. Further, the amount of, take that back. Further, we have developed a specific expertise due to the sheer volume of patients. Doing this for a decade plus, select kind of procedures with very high volume leads itself to, a degree of technical competence and mastery. So treating patients with critical limb ischemia is not something where somebody should dabble. It is something where you should feel passionate about, where you are there to make a difference and save somebody's limb and life. So we pride ourselves in that, unlike probably many groups which, do a couple of cases a week. We are doing a fair number of these due to the sheer number of patients we see. And we take it, that this is what we need to do a good job at it and make a difference to the people where they live rather than making somebody come to our metro area. Dr.
So I
Alterman, would
really
you like?
like that point that you brought out, Dr. Gupta, about a sense of community. Impact, making a difference, coming out to the patients in these underlying, communities that you are serving as your practice. You are looking at not just, the important piece of, providing that care and resource to them, but, it takes it for granted because we're dealing with people from, backgrounds of minorities, and which is interesting because April is National Minority Health Awareness Month. And it's interesting that, the recent study about the Society of Cardiology has actually put together a campaign with regards to Pulse PAD. And they've actually looked at it that between 8 to 10 African American Hispanic patients are not aware that they actually might have peripheral artery disease until they actually come in through the doors. And, if I may, Dr. Alterman, we talk about minorities and we talk about the awareness. Dr. Gupta touched on community. But how important is it when we look at healthcare disparity and the factors that, Dr. Corey and Dr. Diaz-Perera mentioned earlier, when we talk about diabetes mellitus, when we talk about, high blood pressure? How important is it that those communities actually take the initiative to get those screenings to, come through and actually, determine if they could be a candidate? Because Dr. Gupta just mentioned now about critical limb ischemia. We never want a patient to be in a situation where there's immediate intervention needed at the end rather than taking the precautionary measure. Can you please elaborate on that impact of minorities and the fact that how important it is for them to visit a practice such as Vascular Vein Institute of the South?
That's a fantastic question, Vin, and this is something that we contend with on a daily basis as a practice. Oftentimes, it is a lack of recognition, interpretation of symptoms, and also just basically attention to risk factors. Obviously, in the underserved communities we go to, there are massive disparities in healthcare. People fall through the cracks. And, to my partner's point, by the time someone kind of fails the screening process and has lack of recognition, if they are coming to a hospital with severe symptoms and a wound, they are very close to, if not needing immediate amputation. And, the role of our practice is to intervene before patients are so far gone. That's why having all of our clinics in remote communities, as an example, Vin, today I spent the day in Forest City, Arkansas, which is an underserved community. There is a lot of poverty in that county. And I saw several patients come to our office who did not really have the resources to go in to Memphis or to Jackson, Mississippi for evaluation. There was a man in his 50s who came with a non-healing wound for 3 months. He was under the impression it was his nerves, and he was found by way of our on-site testing to have very advanced ischemia. And I believe, if not cared for appropriately, within a few months, he would be facing amputation for sure. So we want to evaluate these more urgent patients. But to your point, education and attention to early symptoms is important to head off some of these issues. And this is why we have educational outreaches. We do community awareness events, lectures, and educations about the signs and symptoms of PAD, as well as risk factor modification, because that's the earliest way to intervene. Even with those educational points, there are still going to be people that are unclear as to whether it's their nerves or arteries, and that's where our practice is, so important. I would say the majority of patients we see in our clinic do not have very advanced PAD. They require education, support, and assistance with medical management, and our practice helps intervene on that.
Right. Yeah, well put, because, again, highlighting to what I said at the beginning and the top of the call, the top of the hour, when we talk about the education, peripheral arterial disease, and it's now starting to come to the fore, I would say the last couple of years. But there's still so much education around that and so much of advancements in technology that has actually been updated. Many years ago, for example, it was the smaller blood vessels that, you could not actually get into to actually be able to treat, right? And it was, a situation whereby, as vascular surgeons, you had obviously determined in terms of, what's your take on this and the analysis. But I think that, we talk about the Tertiary Institute earlier today, but Dr. Diaz-Perera, if I may, we speak about second opinions. We also speak about how important it is for a podiatrist or an endocrinologist, those that are practicing internal medicine, a foot and ankle surgeon, at a PCP, to refer patients over to a practice, with skilled and, vascular surgeons such as yourselves. What would be your take to those patients out there that are interested in second opinions?
Yeah, I think you mentioned two things. One thing is collaborating with other uh, specialists such as endocrinologists and podiatrists. So they, because we are, like we mentioned before, the biggest vascular surgical practice in the tri-state area, spanning across eastern Arkansas, northern Mississippi, and most of West Tennessee. Our brand, if I may use the word, is well known. So we get a lot of referrals from these specialists such as podiatrists and endocrinologists with whom we share uh, patients who have the similar diseases, right? Diabetes, mellitus, high blood pressure, and peripheral arterial disease. So that is a given. We do encourage them to send us more patients for evaluation if they deem appropriate. But beyond that, the more important point that you raised is second opinions. I think this is where we can really make a difference. Dr. Gupta mentioned that we have a wealth of experience and expertise that we have accumulated over the years. And over a physician's lifetime, when you keep doing the same thing, you accumulate a degree of expertise that is not written down anywhere. Uh, I mean, it might sound arrogant to say, but it's very hard to chat GPT our brain sometimes because we instinctively know what to do and how we can save a leg. So even if a patient is told by another specialist or another doctor, nothing else can be done, I think it is always worth their while to come to a group like us, and in this specific case, come to us and get another opinion about the salvageability of the leg, or in other words, can the leg be actually saved? More often than not, we can. In fact, I spent this last Saturday morning, uh, operating on a female who checked herself out of a local hospital and sought a second opinion with us. And as it turned out, she made it just about in time. And I think I was able to get her to a situation where she may go home with her leg intact. So some people, some patients intuitively know that they got to go somewhere and get another opinion. Others don't. We live, in addition to the fried chicken belt, I guess also the Bible belt. People of faith, people are like more inclined to believe than not. So I think the biggest message here is that if you're faced with limb loss, please get another opinion and come to us. More often than not, there's always something we can do, um, both in the short term and the long term.
Yeah. Yeah, that's I think important. It's great that you're using an actual practical example of someone that's been through that, a patient of yours that you saw when you spoke about treating them on that Saturday. So Dr. Corey, I think that we talk about wound care and peripheral artery disease, and that leads me into an important point. Can you explain that link and association there between wound care and peripheral artery disease?
Sure. I think that they go hand in hand. I think that, like Dr. Gupta has mentioned, and Dr. Alterman, a lot of our patients have very advanced disease upon presentation to us, and will present to us with significant wounds on their feet or on their lower legs that are non-healing. And obviously, one of the most important tenets to limb salvage and wound healing would be aggressive revascularization, which we offer. And then after that, it's important that the patients, present to a very good wound specialist. We work with a number of wound specialists that can help perform debridements. Other times there's things like skin substitutes that are used, wound vacs, which are kind of vacuum assisted wound dressings to help accelerate wound healing. And so we work very closely with wound care specialists. It's very common, that I'm constantly being sent pictures of wounds on my patients to assess their progress every single week. And it's important to us that, we're involved in the long-term care of the patients after we see them or after we perform a procedure on them. Wound care is incredibly important.
Okay. So we spoke about the association with wound care and peripheral artery disease. If I may, Dr. Alterman, we talk about patients and, treating them, providing that intervention. How important would you feel is post-operative care after a patient has been seen? You've gone ahead and done the intervention. Is there a recommendation out there that they should be coming back and visiting you at your practice every few months to make sure that everything's in place? Can you please provide a bit of insight to that whole process?
Sure, happy to, Vin. Before I do that, I just wanted to step back one question. You had spoke to Dr. Diaz-Perera about the concept of second opinions and something that our practice takes a lot of effort and pride in. Additional thought, one of the things that we contend with on a daily basis is addressing kind of erroneous notions and dogma. Some people will say, the presence of infection in the bone or osteomyelitis is a hard indication for amputation, which as a blanket statement is not true. Other things that people will say erroneously is, quote, small vessel disease, or the small vessels are, quote, not reconstructible. These are terms that people use to kind of push the amputation narrative, which certainly every limb is not salvageable, but more often than not, when we take a closer look at these factors on a granular level, we see there may be things we can offer. So I just wanted to highlight that this is not a small point in terms of second opinions. This is something our practice does on a regular basis every week. And most legs that are sent to us, we can offer something and give them a chance and hope of limb preservation and save their leg.
A great point.
Getting back to your question about postoperative care and follow-up, we have a fairly robust infrastructure and clinical team to provide close follow-up and support for the patients. This is multifaceted. We have a team of clinical specialists that will call the patients and make sure that they have understood the instructions and that the scheduling process is smooth. The patients can get in when it's convenient for them and see us at appropriate time. We actually start the postoperative process and scheduling during their initial evaluation and treatment to make sure that there are no gaps in care, because that can be a big problem, particularly dealing with wounds. So we can help direct traffic and decide about the need for follow-up wound care, medical therapy, such as starting them on a medication like Plavix. If the patient is not on some medicine to treat their blood pressure, like a statin, we can initiate that, and also discussing tobacco cessation with them. We have a fairly systematic process for follow-up, including routine postoperative care, initiating surveillance, particularly in patients with critical limb ischemia, to make sure we see them through the whole process. A percentage of patients may even need operative repair and bypass, which we can coordinate. And that opens up a whole another set of logistics, coordinating cardiac clearance. This is all encompassed in the care process, and we kind of take pride in being able to micromanage all of these steps.
Okay.
And
Yeah,
when,
that's great.
if I may chime in there, so
Yeah, sure. Go ahead, Dr. Diaz.
this what Dr. Alterman described is, medically speaking, uh, is a big concept, so-called primary prevention and secondary prevention. Primary prevention is preventing a disease from occurring in the first place. But once somebody has got the disease, secondary prevention is preventing that disease causing further complications or progressing. So through everything he described, through this postoperative care we provide longitudinally through the patient's remaining life, we, by instituting all the medical management protocols, surveillance, and further recommendations, and addressing any other manifestations of vascular disease, we are also undertaking this so-called secondary prevention. So that is a huge uh, uh, secondary benefit for these patients. Their vascular disease is being uh, expertly managed with an eye to prevention of further complications.
Yeah. Prevention of further complications. I think that's so important because, patients come in for one thing, they get an evaluation, they realize that this is the situation that they're experiencing, and you want to give them that quality of life. And I think that amongst the four of you with your practice, you've obviously seen patients from different backgrounds, different walks of life. But one thing that's important is bedside manner. One thing that's important is the opinion that a patient leaves in terms of patient satisfaction. Dr. Gupta, if I may, you as a vascular surgeon, you've treated, tons of these type of cases where you've had patients coming in depending on their diagnosis. What would you say is important as a take home for them? When they come over to your practice, what type of level of satisfaction are you expecting them to leave with? The proof is in the pudding ultimately. We see it out there with the reviews that are getting published about the fantastic care that was taken by any of the four of you when it came to a certain patient or the experience that they had. But what would you have a message out there to the patients that are coming over to your practice that they should leave with, feeling that, sort of reassured that they've got the best treatment and the best care?
I think this depends on the stage, you see the patient. So most patients, when they're coming to see a physician, especially a subspecialist for the first time, they have some degree of worry. I mean, somebody coming to see a vascular surgeon, they're generally referred. Some of them, look us up and come directly, but most of them are referred for a specific problem. So in the back of the mind, they're worried that, let's say they have carotid artery disease, they have peripheral arterial disease, they have, vein problems. They come to us, they're worried that, okay, I need to have some kind of surgery. So, a lot of the patients we see, we actually tell them nothing needs to be done in terms, no surgery needs to be done, maybe lifestyle modification, medical management, and they feel a lot better. I mean, patient coming apprehensive leaves us with a plan, leaves us with all these hypothetical worries gone. They feel reassured. Some of them come, for second opinions, or some of them are coming with obviously a significant problem. They have severe rest pain, they have ulcers, gangrene. So they know they have something serious going on.
Mhm.
When they, when we talk to them, we kind of tell them a plan. And the best thing, when you tell somebody a plan, how we are going to make them feel better, a lot of them just with that, they feel reassured that we have a process, how we are going to make them feel better, that the problem will get fixed and rectified, and we have a solution. So fair number of patients we see, they've been told nothing can be done, like we talked about 10, 15 minutes ago. And when you give them a hope, when you give them a plan, I think that itself is so important towards healing and towards getting better, when somebody believes that something can be done. And then obviously proofs in the pudding. Let's say we are operating on somebody, or we are doing an endovascular intervention on somebody. You have to do a good job, and when they come back subsequently, I mean, in our office, for specifically talking about PAD, our crossing and getting through the lesion and then fixing the blockages, or via bypass, I would say is close to 100%. I mean, probably 99% of patients are able to get revascularized. So if you think of it nationally, if you look for patients with critical limb ischemia in the US, amputation rates are between 10 and 20%. For our group, for critical limb ischemia, amputation rate is less than 2%. So significantly lower than the rest of the country. We barely do any amputations because most of these patients, we are able to provide blood flow, get through their blockages. Really, the only patients who need amputation is the leg is dead. I mean, when it says dead is dead, or it's a danger to their life, like they're septic, actively septic, not doing well.
Right.
At that time, you have to do it to save their life. But patients with chronic ischemia, or even with acute ischemia, if it's not endangering their life, we are able to revascularize most of them. And you can see it afterwards when they come see us in the office. I mean, we have had patients dance, patients give testimonials.
Right.
It's a life changer. You save somebody's leg, relieve them of their pain. It's a marked difference to the rest of their life.
Right. And I think, it's never too late. And that's what I love hearing and what I gauge from your conversation right now and your comments, Dr. Gupta. I'm specifically relating to an example that you shared with me of a patient that's 100 years old that had come and seen you recently. And, when you immediately think of, a centennial number like that, 100 years old, they've already lived a remarkable life, but they've got that sense of belief. And it's, they still want to be able to enjoy their life until they very, very much can. And, I remember you sharing with me that, through this process of, you engaging with him and obviously doing that intervention, he's now excited that he's going to be living to 102 and above. It's kind of like these small situations that are so important because it's taken for granted. Here we have a veteran in this case that has been and given up so much of their service, but it's coming to a facility such as yours for you to be able to make that difference in their lives.
That's completely true. I mean, 100-year-old, 90-year-old, I mean, you take somebody's leg. So, somebody with critical limb ischemia at that stage, if you take their leg, they definitely do not have the core strength or the muscle strength in their legs to walk around with a prosthesis. And you consign them to an amputation, they'll be in a nursing home, cannot get around, get infections. I mean, if you look at statistics, I think you alluded to, earlier, people don't know much about PAD. People talk about cancer all the time. So besides a couple of cancers, maybe esophageal, pancreatic, the mortality from major amputation, mortality from peripheral arterial disease is significantly higher than most cancers. Nobody talks about it. You take somebody's leg off, 50% are dead in 2 years.
Right.
Above knee amputation is even higher. And, that's just the stark truth. And, a lot of these are elderly patients. And, people say, it's very easy to say they can get a prosthesis and walk around, except most of them will never have a prosthesis because they're not strong enough. It's not like a 40, 50-year-old, a young gentleman or young lady or an athlete, you take their leg and they're, have a, prosthesis and running around. This is a 80-year-old, 90-year-old. Practically, they're never going to walk with a prosthesis. They're confined to a wheelchair or just, confined to a bed. And
Right.
the demise, the clock starts ticking.
Yeah, very, very true. So, Dr. Diaz Pereira, Dr. Alterman, we're looking at it, we talk about chronic total occlusions. We talk about what's normally treated when it comes to these type of procedures, this endovascular therapy and this arterial intervention. But if you look at it specifically, right, sometimes you get really complex cases, that might require some type of, detour or some type of intervention that is not traditionally that's going to be performed. Can you perhaps share with me some examples of some patients that you might have seen where there's been some really extreme lower cases of revascularization that was needed through your intervention? Whoever wants to go first.
Yeah, I mean, these days we have moved on from traditional open surgical procedures to a lot more newfangled techniques just to capture everything. The so-called chronic total occlusion you're describing is what Dr. Corey was describing earlier, complete blockage of a blood vessel. If I may, I can describe it the way I usually describe this to patients in my office. If you think of a blood vessel like a four-lane highway, when all four lanes are down, that is what we call as chronic total occlusion. You just cannot go through it. You need to take a detour. So in these circumstances, patients are living through their detours, and that is often not enough, just like in a big traffic situation, right? So traditionally, these blockages were fixed with bypass surgeries, which are fun to do for us, but not so much fun for patients. Recovery is long, lengthy hospitalizations. There are incisions, there's scarring, and of course, general anesthesia has its own risks. Uh, Still very doable, great operations in well-selected patients, but that was still a limited option. But these days we have all these other newfangled techniques. These days, the first and foremost, when it comes to minimally invasive techniques, is that we are able to cross these blockages by almost like drilling through it. We get through these blockages with a wire, and depending on the type of lesion, there are multiple techniques to open these, with sometimes with balloons, sometimes with a rotor type of device, sometimes with a laser type of a device, and reopen the native blood vessel. So it's like we reopen a four-lane highway again, and traffic flows through it. So um, then, in addition to that, in extreme cases where we cannot open blood vessels that way, uh, there are some of the newfangled techniques, and my partner, Dr. Gupta, has actually performed uh, one particular operation on at least two patients in Memphis. He was the first one to do so in Memphis, and he can elaborate on that later. In addition to that, when there's nothing else that can be done, there are still extreme open operations we can still offer patients. These may seem like last resort operations. They are actually not last resort, or a situation where you're throwing everything at the kitchen sink at it. But these operations we reserve because they have their own unique complications and risks. We preserve those operations for patients who actually need them, and then everything, all other options have been exhausted. So the repertoire is big, from traditional open surgery to newfangled crossing techniques to open these blood vessels, to some other newest innovations where we can get blood flow to the extremities in numerous ways. I think Dr. Alterman and Dr. Gupta will touch on some of these.
I like
Yeah.
the analogy there, Dr. Diaz-Perera, of the 4-lane highway. I think that's a great insight.
So I can chime in what Dr. Diaz-Perera alluded to, and yes, that analogy is perfect. So, there's complicated open surgical revascularization options, and then opening the 4-lane highway through endovascular methods, minimally invasively without incisions or just with poke holes. I think, over the last decade or so, there have been so many advancements. We do what's called atherectomy, which is really a rotor. So to do that, to open somebody's native blood vessels, you have to put a wire through it. So if you think of it, for a layman, you put a wire as a rail through the native blood vessel, and over the rail you work. So you could put a rotor through it, clean out the plaque, and then balloon it open. And if needed, put a stent, which is a metal scaffold. Now, the hardest part in doing these is to get through the blockage. So that, for us, involves access, where you access and enter the blood vessel. Traditionally, it's been done in the groin. In our practice, we do that. We also go at the ankle, we go behind the knee, we go at the left, the right wrist, we go in the shoulder area, we go in at the bottom of the foot. There are multiple options, you know essentially wherever it's needed we access. A lot of people don't do that. you know Traditionally they would just go in the groin and stop. Where we differ is we access everywhere is that's needed, and then once you get through it, you clean it out, balloon stent. And then patients, you cannot, there's some patients there's no other option. So what Dr. Diaz-Perera was mentioning is procedure called deep venous arterialization, where we actually convert somebody's own vein into an artery. So arteries are the blood vessels which get blocked and which we open in these cases, and arteries take the blood from the heart to the tissues. Veins actually take the blood back to the heart. So that's the difference between arteries and veins. But here, what we are doing is we are converting a vein into an artery and connecting it to the artery. And thus, the vein, arterialized vein, now provides blood flow to the foot. And that is needed in patients where there are no targets to connect to or to bypass to. I mean, what we call a desert foot, like somebody who has absolutely nothing in the foot that you can connect to or open to or do open surgery to. In those patients, you take a vein and make it into an artery, and that provides flow. And that works pretty good. Patients heal and get better. And it's a newer evolving technology, came out like a year ago.
Yeah.
So, yeah.
Vin,
Great.
I would also chime in and reiterate what my partners have described, that for sure our practice is on the forefront and cutting edge of the latest techniques and technologies in terms of the scope and breadth of tools that are used to treat the CTOs or complete blockages. We truly have expertise in the gamut. The Dr. Diaz-Perera mentioned the standard rerouting or bypass around, taking a detour with vein bypass is appropriate for some patients. And collectively, our practice has close to, if not more than 50 years of experience in these tools. Looking at the scope and history of the endovascular techniques, as Dr. Gupta was mentioning, in the last several years, there's been newer, kind of more advanced techniques to deal with so-called untreatable conditions. Looking back historically, the original kind of rudimentary or crude techniques that were used, just passing dilators into vessels in the 1960s, and then in the 70s and 80s, so-called subintimal angioplasty was considered state-of-the-art technique. In the interim, there's been an explosion of tools and techniques that have been available on the U.S. market and cleared by FDA, but thoughtful application and experience with these is so important. Even combining these tools and techniques in novel hybrid ways is something that our practice does well, if not better than most practices in the country, and this is borne out by our limb salvage rates. Combining these techniques and tools to things such as distal angioplasty, the so-called pedal loop technique, novel accesses from the upper extremity. All of these things, we can offer a patient a full palette of therapy that they would be hard pressed to find elsewhere. And this gives them ultimately more options for limb preservation.
Yeah, well said, Dr. Alterman. I think, we talk about techniques and the changes that have come through that, and it's all about innovation. And, a practice such as yours that is a leader in that space in your region, I think that, it's reassuring not only for patients, but also, it goes back to the whole process of what can you do, that's minimally invasive to be able to treat them to the best, of your ability and give them the type of results that they are looking for with patients that are putting their trust into you. And, coming to that word trust, we talk about the recognition that providers, physicians, clinicians, doctors, whatever term you want to use, vascular surgeons such as yourselves have received when it comes to commendations and accolades within the industry. And I think there's nothing bigger than any peer-to-peer recognition. So I would like to highlight the Castle Connolly achievement specifically that, your practice was able to get with your providers. How important is that to you as a practice there, Dr. Corey, Dr. Gupta, that you basically have this recognition whereby you are knowing that it's not something that's put out for any advertising, it's not something that's put out for popular voting, but it's actually recommended by peers and colleagues from you that you are a distinct practice choice or selection when it comes to Castle Connolly Top Doctors 2026.
I think it's a validation of, as a practice, who we are and what we bring. And, it kind of validates and tells us that other physicians in the community, because it's, purely peer-to-peer, that they know who we are, recognize who we are, and, consider it worthy to rank us top doctors in our specialty and, send us patients and, hopefully, because, it's anonymous, so we don't know who's voting. So,
Right.
and hopefully, we have a lot of mutual patients and we are doing a good job and, making a difference in the community. And it's probably a reflection, and that is probably a reflection of, why, people or whoever's voting for us, vote for us.
Okay. Anything you'd like to add onto that, Dr. Corey?
I think Dr. Gupta said it well. I mean, we work really hard for our patients. You know, our relationships with our patients are so important to us, and taking care of our patients on a daily basis. It's nice to see that other physicians in our community recognize our commitment to our patients and that we try to do the best we can for them. I think it's it's a true testament to everyone in the group, as to our tireless work ethic, um, our abilities, and I think it's a nice recognition that we received, and I think that we're very happy to care for all patients in Memphis and the community.
Okay, great.
And I'll add to that. I mean, ours is the only group in a 200-mile radius. Ballpark 200-mile radius, who's been nominated to Castle Connolly Top Doctors 3 years in a row, at least. I don't think there's any other local group in Memphis with that long a history for vascular surgery, and nowhere, maybe Nashville would be the closest, somebody else would be. So it's a
Right.
pretty catchment area as well.
Yeah, I think, we talk about your practice in particular, and it is not a practice that just has one location. It spans, different miles, it spans different boundaries in terms of neighboring states. How important is building a brand within the community to as a practice for you as the physician owners and operators? How important it is that someone recognizes that this is, for example, that particular clinic that provides that type of care, because at the end of the day, and I come from a marketing background, so I think it's a very relevant question. That quite often physicians or clinicians, we look at a physician or a doctor, and they've got this particular review, or they are being able to treat this particular, patient. But in today's day and age, where there's so much of choice, right? There's a plethora of information online. There's, the ability for patients to search, particular clinics that are out there. What would you say is the importance of that brand recognition for you as a practice? And it doesn't mean because it's Vascular Vein Institute of the South, even if it were to be a different name. How do you see that as being importance within the community and branding for you as a practice?
I'll take that question, Wayne. So it what seems like a branding exercise is actually much more than that. What we are trying to achieve is to create an institution with a level of expertise that far exceeds anything that we have in this area, purely because the region needs it. So, and and branding helps in promoting ourselves across the region, but branding also helps in getting the physicians to collaborate together. Like we have the four of us here. I don't know whether you knew this. Uh, Back in late last century, early part of the last century, the top physicists always went to Max Planck Institute to study physics. Even Albert Einstein went there because that's where all the best physicists would gather to research physics. So similarly, when you have a brand name, you also attract the best talent, the best experts, and in turn that translates into expert, in our case, vascular care. So so that is one facet of branding that helps with what we do. Of course, it attracts patients, and they would know where to go for their expert vascular care. And in turn, when they come to us, we are able to offer a level of expertise that is not available anywhere else.
Okay. I think well said, in terms of the connotation that you alluded to there, Dr. Diaz-Perera. But I think that, this has been a great conversation, in terms of, touching on various aspects and the importance thereof as a practice such as yours. And, again, coming back to the fact that saving limbs, saving lives, being able to, assist those patients that I need. Is there any parting thoughts that you as vascular surgeons would like to relay with the audience in terms of, what is it that, if there's anything that you could take out of this, that patients need to be prepared for or concerned about when it comes to the overall vascular health, and to making sure that they can prevent those amputations and kind of, be on their feet, living sort of a pain-free life?
I guess we can go around the table, but I'll start with one. If your foot's not already dead, we'll find a way to get blood flow down there. So come to us for a second opinion.
I was actually going to say the same thing, and that's probably the most important point. There are a lot of people who dabble in what we do in the city or neighboring areas. It is very different. You come to somebody who does this full time versus somebody who dabbles in it, and somebody who doesn't follow patients longitudinally and somebody who does. It's easy to say, take the leg off, and patients don't realize what their life would be once the leg is gone. Always seek a second opinion, third opinion. Our amputation rates are probably one of the lowest in the country at our place, at our institute. And it's extremely rare we cannot save somebody's leg. So this goes to other physicians, and this also patients seek another opinion. We can make a difference. And if somebody loses a leg, their life is markedly changed forever. It's not a small thing.
Sure. And, to add on that, Vin, I would say that, the scope of our service and complexity of our practice is, what we would characterize as being full service. Patients have all the options on the table. A lot of people use the moniker vascular, but, they may or may not, they're different varieties of so-called vascular specialists, but as modern vascular surgeons, having a variety of both surgical, non-surgical, less invasive, and combinations thereof treatments, we can truly offer a full spectrum of treatments to treat people's peripheral arterial disease and also save their legs.
I would also agree. I would agree with all those points, but I will say one of the best things that I think about vascular surgery is that you really have it's one of the few surgical specialties where you really have a longitudinal relationship and a long-term relationship with your patients. Peripheral arterial disease in particular is a chronic illness, and we have the benefit of engaging in a patient-doctor relationship with our patients that is long lasting. And we help patients through some of the hardest times in their lives. And I think that is one of the beauties of our specialty. We really get to know our patients, and we follow them over time and help them in many different ways. And I think that's one of the most rewarding things about our specialty and our practice in particular.
Okay. Fantastic. Well said. Well, thank you, everybody. Thank you, Dr. Alterman. Thank you, Dr. Perera. Thank you, Dr. Gupta. Thank you, Dr. Corey. It was a pleasure having you all on this particular podcast. I'm excited to learn about some of the developments and great things that, you've got planned for Vascular Vein Institute of the South as you progress. But I think the message is important that at the end of the day, if patients are being impacted in any way with regards to this vascular disease, in and around the locations that you serve, there is no other alternate place they should even consider, given the fact that you're bringing this to the table today and providing that education piece, and and results practice that has been able to make such a difference within the community and entrench themselves within the community as a brand, but more importantly as a place that patients can come to when they're experiencing this severe leg pain and issues regarding their vascular health. You have a lovely evening and take care.
Thank you so much. Thank you so
Thank
much.
you, Ben.
Thank you.
All right.
Okay, bye-bye.
Thank you.